There are considerable advances in the treatment of metastatic sarcoma. Clearly, on one hand, by drug therapy, but on the other hand, mainly in the interaction between drug therapy and local measures. Local measures does not mean only surgical resection. It also means radiofrequency ablation. It might mean irreversible electroporation. It might mean techniques of stereotactic radiation therapy to destroy solitary or single metastases, but also lung or even soft tissue resection of metastatic disease has evolved. The main trigger behind that, I think, is the better separation between those patients who might profit from it in comparison to those where it is only technically feasible. For the patient, the question is, does it make sense to undergo surgery, or are there other techniques that also could end with the same treatment result? And with re-adopting the concept of oligometastatic disease, that means patients have single metastases, one after the other, to different organs, but never have widespread metastases at the same time. That's a better allows a better selection of patients. There is not a uniformly adopted policy for how to handle metastatic sarcoma. It is quite different from the different sarcoma subtypes. You will handle it differently in gastrointestinal stromal tumor, where there is no scientific proof that removal of the metastasis by surgical means really adds to the prognosis of the patient in terms of overall survival. On the other hand, looking for soft tissue sarcoma, it is quite clear that with an adequate selection of patients, you no longer have a median survival of 1 year after detection of the metastasis, but probably 2 years or even longer. This has not yet come together or been brought together to a guideline saying, in case you have this, do A, in case you have this, do B. It's generally said, okay, positive prognostic factors are long interval between primary tumor and metastatic disease. Best is more than 2 years. Okay, you're happy if it's more than 1 year also. The longer it takes, let's say, the less aggressive is the overall behavior of the tumor. This opens the door to an adopted policy saying, okay, patients with long interval to the onset of metastasis might have better profit, and those with few metastases might also have more profit than those with widespread metastasis, for example, to all over the liver or to both of the lungs. And there are better techniques nowadays to detect those tumors. There are better techniques, let's say, to remove those tumors with less morbidity for the patients.